Endobiogenie workshop organized with Dr. Hedayat. It is my pleasure to thank Zenit as a sponsor of this event, and without them, most probably, this wouldn't have happened in this format. So, Zenit is one of the leaders of the Romanian food supplements market. Zenit is a 100% Romanian company whose portfolio currently includes over 150 premium products for a functional approach to health. Zenit motto is more education, more health. Starting from this motto, the Better Medicine Project was born. A community of specialists passionate about functional medicine and focusing to create healing at the root cause. Better Medicine supports specialists and the general public on their journey towards healthy lifestyle by organizing webinars and by supporting medical events with renowned specialists, such as today's workshop. Paul Ailinkoi, the founder of Zenit Pharmaceuticals, is the one who helped today's event make happen. He's the manager of Zenit, and he's passionate not only about the field in which he works, but also about education for a healthy lifestyle. Together with his team, Paul is constantly studying to create innovative formulas and premium health products, along with promoting functional medicine in Romania. It is my honor to introduce Dr. Hedayat. Dr. Hedayat was trained at Stanford University in pediatric critical care. And he was the director of intensive care and integrative medicine, where he created the first holistic pediatric intensive care unit patient setting. He's the chief scientific officer at the System Biology Research Group. He's the course director and chief architect of GEMA Biomarker Analytical System. Dr. Hedayat is teaching endobiogeny, and he's the most prominent teacher all over the world. He also wrote the books that most of us learn from, and it is a 4-volume series that basically sets the stone of endobiogeny theory and clinical application. Endobiogeny is an approach to medicine that is rooted in the modern language of science and based on the whole system approach to integrative physiology. The goal of clinical endobiogeny is to return the physician to his or her place as a healer and bringer of health, not just a manager of illness. Endobiogeny was developed by Dr. Christian Durafort of Paris, France, throughout the 70s and 80s. Along with his practice partner, Dr. Labraz, a set of teachings were developed and taught throughout the world over the last 45 years. Dr. Hedayat apprenticed under Dr. Labraz and has been responsible for the systematization and expansion of the endobiogenic concepts. Let's welcome Dr. Hedayat.
Thank you. Well, before we begin the course, I just want to show you how I live endobiogeny, because I'm going to go through a series of increasingly upstream levels of thanks. So first I want to thank my wife, Brigitte. Many of you know her. She was not able to attend today because of illness, but hopefully she'll be better by tomorrow. And I want to express my deepest gratitude to Alexandra for organizing all of this. She has been a true gift to us here in Romania, so thank you. She's been generous, hardworking, efficient, and has expressed a real passion, so thank you, Alexandra. And it is because of Alexandra's initiative that Zenith very generously has agreed to support this educational program, which is in line with their vision of better educated physicians means better use of natural therapies for healing and health. And I would not be here in Romania at all if it wasn't for Dr. Camilla Aubert of Cluj. So I want to thank her as well as we keep going further and further upstream. And of course, I want to thank Dr. Lapraz for being my mentor, for being so patient with me. And to really go upstream, I want to thank my parents who are both in the medical field, and my mother especially, who was so patient with me all throughout my life and let me ask her lots of questions. She was my first teacher in integrative medicine because even though she was a nurse anesthetist, she always treated me with Iranian herbs and rose water and seasonal eating. And I grew up thinking medicine exists on a spectrum, and the more severe the symptoms are, the more powerful or focused the treatment is, and the less severe, the more self-limited, the more gentle the treatments can be. So this is how I got here before all of you. Before we begin, I just want to take a quick survey. How many of you are new to endobiogeny today? Okay, wonderful. Okay, so there's going to be a short introduction to endobiogeny, just kind of give you some ideas. When you're new to endobiogeny, even if you've been studying with us, sometimes it can feel overwhelming. And that's okay. If you don't feel overwhelmed, you're not paying attention, okay? Today, more than teaching you something, I'm going to help you unlearn things that you have learned in your medical training that have not been helpful and have prevented you from coming to this or delayed it. How many of you have some training or use medicinal plants in your practice? Okay, so a number of you do. Okay, for those of you who do not, or say, well, I use it sometimes, but I'm not confident, we're going to have a course that starts in March that's clinical endobiogeny, and we're going to explicitly teach you how to use the plants in a general sense and for specific disorders. So don't worry. Today, I want you to feel that you're on a hot air balloon and you're just floating over this kingdom of endobiogeny, and at any time we can go down to details. All right. So let's get started with a brief introduction, and then I'm going to introduce your teaching material, the clinical material, and then we'll get started. All right, so let's talk a little bit about endobiogeny. We're going to talk about what endobiogeny is, how it works, how it can improve your approach to healing, and then 4 essential understandings or takeaways. And then we'll just conclude by comparing endobiogeny to other forms of integrative medicine and other non-Western approaches to whole system medicine. So what is the theory of endobiogeny? Well, in the Eastern approach, I think as many of you know here in Romania, Eastern approaches like Ayurveda or Chinese medicine are whole systems approaches to medicine. But the language they use involves the concepts of forces and elements. Whereas endobiogeny is also a whole systems approach to thinking, but it's based on Western physiology. So the language we use is the language of our times, which is physiology, metabolism, etc. And endobiogeny is a theory of the interconnectivity of all living beings and all elements within a living being. What we seek to understand for each individual is how the elements of metabolism, physiology, perception, psychology together can maintain health or bring about disease. And we don't just look at it within the person themselves. In a broader sense, as we'll see today in our case study, we want to understand how the individual is interconnected and related to the other people in their life and the environment in which they live. If I walk around, will that be okay? Yeah, okay. I'm a bit of a peripatetic. I like to walk around like Avicenna. Okay, so what is the advantage of endobiogeny? It respects the whole person. Our goal is not to break the human being down into their cellular or biochemical level of existence, but to reintegrate that reality into something greater. But it's rooted in contemporary science, in our science, and in the language that we use today. And it utilizes standard medical and traditional healing modalities. I really want to emphasize that for me as an endobiogenist, chemotherapy is an option for some patients. Glucocorticoids are an option that I consider. Levothyroxine is an option that I consider. But only when these other treatments have not been helpful, or only when the patient has surpassed their possibility of self-healing, of spontaneous healing. But nothing is off the table. I'm going to close this door. Okay. So let's talk about metabolism. Life is metabolism. It is fundamentally this holism of metabolism circumscribing a duality. And this duality is expressed through catabolism, which is breaking material down, and anabolism, which is building material up. And this basic dualism of life is expressed at all levels. We can talk about food, energy, tissues, ideas. It doesn't matter. Everything in the universe is constantly undergoing a type of metabolic process. You know, it's interesting, in Stoic philosophy in ancient Greece, they talked about universal metabolism, like the metabolism of the universe itself, and how ideas and energies are constantly being transformed and transmuted. So metabolism is a universal concept, and you can apply it fractally at every level of existence about every process which occurs. Now, the universe, generally speaking, is orderly. Even when there's chaos, there's ordered chaos. There's a purpose to this chaos. And something has to be managing this orderly process of metabolism in order for the universe to have the integrity that it has, that every day when we wake up, we still exist. And despite all the challenges we face, we're able to persist and continue living. And that system that ensures the orderly management of biological metabolism is the endocrine system, the hormones. Hormones are the master regulators of metabolism because they ensure coherence, order, and the larger plan of metabolism. Sorry. So it is thanks to our hormones that as human beings we have the potential to go from surviving to thriving, and why we have the ability to live a life that is richer than an insect or a lizard, because we can not just focus on our organic existence, we can go for something, we can live in a larger sense. So metabolism is the transformation of energy and material for life. But I stated that endobiogeny is the study of integrative physiology. So what is the difference between physiology and metabolism? Physiology is all of the processes in the body that allow metabolism to occur and which remove waste products. So physiology includes cardiovascular and cardiopulmonary activity, because we have to take in oxygen and circulate it. It involves digestive activity. It involves emunctory organs like the liver, the kidney. It involves the lymphatics, the intestines for removing the waste products. All of this is part of physiology. And physiology is what it ensures that metabolism at the cellular level is able to occur. Now, integrative physiology is looking at all the levels of existence at the same time. And it is integrating cell, tissue, organ, and the whole body. It is integrating the different families of hormones and their catabolic and anabolic activity. And this integrative approach to physiology is what allows us to create the disease models that we have in order to determine how to rationally and systematically approach every illness. So I'm going to put all this information together in a little animation. Remember, we talked about this unitary concept of metabolism. And then there's the dualistic concept of catabolism and anabolism. And this duality is under the management of the endocrine system. Why do we say that, and how is that so? So we have these 4 lines or 4 axes, 4 families of hormones. We have the corticotropic here, which includes cortisol. We have the gonadotropic, which includes estrogen and testosterone. We have the thyrotropic, which includes T4 and T3. And we have the somatotropic with insulin, prolactin, growth hormone, etc. The reason they're arranged in this order is because the overall effects of these families of hormones is generally catabolic, anabolic, catabolic, anabolic. And sequentially, whenever the body is facing some type of major challenge, it will respond in a sequential way. I'm going to get a little bit ahead of ourselves. Some of our students might feel comfortable with what I'm going to say. Some of you might not. When we're talking about a specific disorder, it is always going to be a combination of an autonomic nervous system imbalance, a hormone imbalance, and a functional balance. So when we come to our case, for example, we'll talk about where do we start in this order to specifically look at a specific condition. So here's the autonomic nervous system on your left. Come on in, hello. So there's just a sequence that starts with parasympathetic, which includes the vagus nerve. We have alpha sympathetic, which is noradrenaline, and then beta sympathetic, which is adrenaline. So there's a sequence of events that is occurring. And so thanks to this activity, we really talk about a neuroendocrine manager, because the endocrine system is the true manager, but it doesn't work alone. The autonomic nervous system is going to be telling it how long, how intensely to work, when to begin, when to stop. And then there are key emunctories that are associated with these different families, and we'll get to this in our case. All right. So as a result of this framework that we're working in, we can understand the origin of every disorder that's not genetic in nature. Because there will always be a combination of these 3 factors: hormones, the autonomic nervous system, and a functional organ. And when we build these constructs for each disorder, then you know rationally where to start, with which group of hormones, with which aspect of the nervous system, with which functional organs. So this is a table which just very practically shows you how this thinking works. Let's say a patient presents with acne. Well, acne is not a skin disorder. It's a systemic disorder which expresses on the skin. And fundamentally, there's too much parasympathetic activity, and the gonadotropic axis, which includes the sex hormones, are overactive. And there's trouble managing proteins. And because the liver and gallbladder and the colon are congested and they're not sufficiently excreting these proteinaceous waste products, the skin becomes an emunctory organ, a detoxification and excretion order of last resort. And those proteins are pushed up to the skin, and you have acne. And then there's a reason why there's cystic acne versus a comedal acne. So we won't get into that today, but there's an explanation for that. And so even if you are unclear on exactly how to treat acne from this perspective, you can always drain the liver, the colon, and the skin. And wild pansy, Viola tricolor, does all of that. So when we think about this from an endobiogenic perspective, remember this is our model that I showed you earlier? Well, we can overlay the activity of Viola tricolor and see how efficiently it addresses all these things. The dysbiosis, which is associated with acne, the congestion at the level of the skin, the congestion at the level of the liver, issues related to excessive carbohydrates, congesting the lungs to breathe out the carbon dioxide waste product of carbohydrate metabolism, the pressure on the liver, the immune dysregulation that leads to the inflammatory component of acne, and it helps with wound healing, so it helps with scarring acne. So what I want to tell you is even when things sound very complex, I want to encourage you to start applying endobiogenic thinking at the level of the emunctories. And I always tell my students, if you don't know what to do, drain. If you don't know what to drain, drain the liver. And a lot of these hepatic drainers also have these other benefits, like wild pansy. Okay. So this is the theory of endobiogeny. Now, how do we actually practice endobiogeny? There's 4 elements. Listening to the patient, because we want to understand the symptoms related to physiology. You know, for the last few years, there's been a lot of talk. And as a matter of fact, in this hotel, there's a conference on big data. And people were concerned that AI and ChatGPT are going to take over our job. You can obtain more big data about your patient if you sit down and listen to them for 15 minutes than any computer could try to extract. And this is what we teach in our clinical course, is how to obtain the big data by looking at your patient, by listening to them, the words they use, the metaphors, how they breathe, the temperature of their skin, everything. You can get a read of your patient. We want to examine the patient to determine the semiology related to the physiology. We want to evaluate biomarkers as indicators of physiologic activity, and we want to offer an intervention through a rational synthesis of these first 3 levels that's based on the evidence before us. Really one of the great advantages of endobiogeny with our biomarker analytical system is that it provides a numerical and objective way of communicating to your patient and to your colleagues the imbalances in the patient's terrain. And this is in no means to make light of the greatness of the whole system's approaches to medicine like Ayurveda and Chinese medicine that came before us. But many practitioners will never master pulse diagnosis or tongue diagnosis. And even if they do, it is a subjective art. And to convey to another practitioner what you felt in the pulse is challenging. But to present a report with numerical data which says histamine activity is estimated to be at this and cortisol is estimated to be at that, and there's this much level of necrosis going on systemically, this is something we can all look at together and understand. So listening to the patient, the anamnesis provides information about the past, the present, latency of future disease. So in these examples, I'm just going to talk about alpha sympathetic, which is that part of the autonomic nervous system that uses noradrenaline. So if your patient has teeth grinding, tense muscles, insomnia, anxiety, you know they have elevated noradrenaline. You do not have to do an expensive urinary neurotransmitter test to know that they have elevated noradrenaline. When you examine the patient, you want to corroborate the information from the anamnesis. I think the greatest sickness of modern medicine is certainty. Modern medicine is on a quest to be certain about everything. And really, from my perspective, we can never be completely certain about anything because everything is happening all at once. But we can come as close as possible by removing the greatest amount of uncertainty from our assessment. And that occurs through an overlapping of the information we obtain from the history, from the examination, and from the blood analysis. And wherever those overlap, you can have the lowest level of uncertainty and the highest level of certainty and say, I'm ready to prescribe a rational treatment. So on examination, if your patient has deep vertical wrinkles that look like their face has been cut, for example, very deep wrinkles, that means chronically they've had elevated alpha sympathetic activity. If they have injected sclera, so the vasculature on the sclera is very prominent, that would be another sign. A strong response on glabellar tap here, if any of you do neurologic examination, where the eyelids will rapidly blink. And then we're going to evaluate the blood work. But we're not going to just look at the blood work in a binary fashion. Is it high or low? We're going to understand how the relationship between the different biomarkers create a network that shows how close or far a person is from their optimal state of health. Because if we said everyone has to wear a shoe which is between size 40 and 44, because that is the mean or average foot size, that is absurd. Because somebody has a small foot, somebody has a large foot, somebody has a wide foot. Everyone has their own optimal shoe size. And we can't make everyone wear the same shoes. And in the same way, what's normal for one person is abnormal for another. Or what is normal at one time is inappropriate for another. Dr. Irina and I were speaking over lunch today, and we were sharing our work in critical care medicine and talking about how inappropriate it is to have a normal level of white blood cells, of leukocytes, when you're in a phase of critical illness. You should be very concerned if your patient has normal leukocytes, right? So the concept of normal, we need to put that aside and think about appropriate and optimal given the terrain and the demands on the organism. So our approach to analyzing biomarkers, of course we're going to look at biomarkers in the classical way. I mean, if someone has an ALT, a liver enzyme, that's 8 times above normal, it is what it is. There's no special endobiogenic thinking on this. This is just a good approach to medicine. The problem is most of our patients have symptoms with normal labs. And sometimes they have abnormal labs but no symptoms. And either way, we're at a loss to explain it. So our approach is algorithmic and mathematical. And what we're looking at is an imbalance in drift patterns. The drift here means how far you're moving away from your optimal state. It allows us to have an objective numerical and at the same time qualitative analysis. Because again, we're not just going to be looking at one factor. We want to look at one factor relative to another. Again, even in classical medicine, if you're looking at cardiac activity and you're looking at cardiac output, okay, well, if you want to know how well oxygenated a patient is, you can't just look at the cardiac output. You need to look at the pulmonary function, right? And you need to look at renal competency. Because if they're in renal failure and then they develop pulmonary edema, what does it matter what their cardiac output is? They just don't have enough oxygen to circulate. So we need to think in this relativistic or qualitative sense, because life is not about a single person or single organ. Sorry, I want to give you the analogy that a government, a country is not a single leader. I know many countries and leaders think that way, but the country is everything and everyone and how everything works together, and it's the same thing about the body. So this is an example from our thyroid quantitative analysis panel. So we take TSH and T4 and we create a ratio. And you can see that in this case, the individual hormones are normal because they're in the green zone, and the drift profile, which is the ratio, is also normal. But you can have a situation here where the ratio is high, but it's specifically because the T4 is suboptimally low. So you need to look at the drift profile and the individual factors to understand, well, where do I need to treat? Because, for example, the ratio is also high, but this time it's because the TSH is high. So we're going to teach you how to think in this way. And a high ratio, but not the individual results, have been associated with a greater risk of dementia and worse glycemic control in diabetics. That's why evaluating these types of functional relationships becomes important and relevant. This is a low ratio of the TSH to T4. And again, the individual values are completely normal and optimal. And this is associated with a lower risk of dementia and better glycemic control. So just like that, with this analysis, you can start to profoundly impact current disease and latent risk of disease. So how do we do this? We have a testing system, GEMMAbio.com. GEMMA is an acronym for Global Endobiogeny Mathematical Medical Assessment. And we have proprietary algorithms that can help you deeply understand these imbalances, screening and prevention. Every report offers a diagnostic and therapeutic aid to help you better understand the results, and also how to rationally recommend different types of treatments, medicinal plants, vitamins, minerals, lifestyle, diet, etc. And compared to other functional testing systems, the cost is quite low because we're taking common blood tests and we're doing a secondary analysis on them. We're modeling, not measuring. We're extrapolating through physiologic relationships. And a growing number of our reports will also include drug-drug, drug-herb, and herb-herb interactions that you want to be aware of to safely prescribe medications and medicinal plants at the same time. This is just an example of a few of the tests, but we're actually going to go through these together for our case today. And okay, it looks like this is off a little bit, but okay. Yes, so we can look at things like anxiety, inflammation, immune dysfunction, allergic, adrenals, thyroid. We're actually going to go through the report so we can skip through this. This is an example of one of the diets that you can find. It'll help you educate your patients and identify the most helpful foods for them to use for different conditions. We also offer some guidance on environmental medicine and toxicity, as well as psycho-emotional imbalances. And this is an example of iatrogenic issues related to thyroid dysfunction, related to, sulfonamides, PTU, amiodarone, etc., lithium. Every panel, every report includes a little clinical reminder for you of the symptoms that are associated and the signs with the conditions that you're evaluating. So you can correlate the biomarker results with the clinical findings. And then there's like a little course for you at the end that rationally explains how did we derive these ratios? What are the studies we based it on? Why did we construct the indexes the way that we did? This is just an example at US prices. If you have a patient who's anxious, you could order a full profile to do anxiety level 3. Well, it'll automatically tell you what type of anxiety and what the score is. If it's situational or generalized anxiety, it'll look at the GABA and endorphin balance, serotonin activity, cerebral inflammation, brain inflammation, and cortisol, which are all factors related to anxiety. If you wanted, so that would cost about $150 in the United States, and the results would be back in less than a week. If you wanted to order urinary transmitters to quantitatively measure them, it would cost about $350, so over twice as much, and take 2 to 4 weeks for the results to come back. A lot of the tests that we offer only require a hemogram, is that what you call it?
Yes.
Right? Yes, a hemogram. And you can have the results in 24 hours. I mean, as soon as you enter the labs in our testing system, you'll get the results in 2 minutes, and you can immediately talk about it with your patient. And the treatment choices are going to be rationally selected based on your findings, but they're not limited to anything I've spoken about today. At one point, I ran a clinic that had hyperbaric oxygen, intravenous nutrition therapy. You know, we had acupuncture, we had psychodynamic therapy for patients. You can use whatever you want, homeopathy, medicinal mushrooms, plants, anything, acupuncture, whatever you use, whatever's in your area of expertise, you're going to use it more confidently with our system. So why does it benefit your practice? I'm just going to cool this down a little bit. It's transposable, it's not imposable. Endobiogeny is a framework, an analytical framework and a philosophy of life into which you can bring whatever you've been trained in to practice it more profoundly. Studying with us expands your knowledge base. It brings profound insights and deep knowledge, and it supports the transition to a more satisfying and lucrative patient-centered care model. It helps better address the quote-unquote unsolvable and untreatable conditions that you're faced with. So in summary, endobiogeny combines holism and physiology for integrative physiology. It evaluates metabolism, it models physiology, and this approach of modeling physiology with biomarkers is cost efficient, it's effective, and it brings a very profound level of knowledge. And we promote patient-centered care with deeper insights and a wider range of treatment options to offer your patients. So where does endobiogeny fit into everything you've learned? Well, endobiogeny as a philosophy is systems thinking. And it encompasses everything, basically. But we have here standard biomedicine that we're all trained in, which is non-integrating physiology and mechanistic. And you have functional medicine, which I would say is holistic biochemistry. And you have orthomolecular medicine, which is functional biochemistry. And you have the theory of endobiogeny, which is a physiology-based approach to systems medicine. So endobiogeny is built on this foundation. We don't disregard any of this. It's incorporated into this. And then we have pre-modern whole systems medicine, East Asian medicine, Ayurveda, Tib Unani, other forms. And there's a type of respect and complementarity between our approaches. The advantage that we offer people trained in these approaches is quantification, which is lacking from their system. And also a languaging and a messaging to communicate results to patients. Because patients in our world do not understand the concept of stagnant liver qi, for example, that is not resonating with our people, with our time, with our culture. And endobiogeny as a philosophy of life encompasses all of this. Okay, any questions before we talk about training opportunities? All right, let's go on. So if you're interested in holistic medicine, in healing your patient versus just treating symptoms, or transforming your practice for greater enjoyment of medicine and patient care, you'd be a good candidate to study with us. We have a new course that begins in March of next year. It's called Clinical Endobiogeny Level 1. This is for people who say, I want to know how to do this. I want to know how to apply this. It is going to be a live course, but you can also learn asynchronously, meaning if you fall behind or you need a different pace of learning, all the lectures are recorded and you can watch them at your own pace, or you can participate live. We're going to have more explicit teachings on how to use medicinal plants for root cause treatment. And we have a course which we're currently completing called The Science of Endobiogeny. And this is for people who say, I want to know why. I know a lot of you said that, and that's why you're in the course. So because the course is already ongoing, if you're interested in studying endobiogeny and you want to know the foundational science first, you can take this course at your own pace because everything has been recorded. And you have up to 18 months to complete the course, even though it's a 6-month course. Same thing with this one. If you start the course, something happens in your life, or you need more time, or you want to study it twice, it's okay. You have 18 months to finish every course. So the Science of Endobiogeny, well, both of these courses, what's nice is we have a learning management system. For every module, you have all the reading material. There is a 2-page summary of what the chapter is about that you'll be reading. There's a self-assessment test with answers for every chapter to help you focus your learning and make sure that you're learning appropriately. And we always have a combination of theoretical and experiential learning. And you can take a certification test if you want, and you can also apply for a diploma. So the new course will also be a 6-month course, and it'll be very similar, except we'll be studying the Theory of Endobiogeny, Volume 2. So your tuition includes all the material that you need in electronic format. If you want to buy a book, you can buy it. If you don't, you'll have the electronic book. It includes all the workshops, the case studies, the course videos. Like this program was not planned, but I'm here and I'm really happy to be with you guys today. So whenever these opportunities arrive, there'll be these additional learning opportunities. Okay, you have some information with you, and there's a QR code you can scan. If you don't like to use QR codes, there's also this website you can go to, training.systemsbrg.com. You can learn more at our general website. You can read my research studies, the clinical studies that I've conducted on the indexes and how we model. If you're curious, you can go to Gemma Bio. You can sign up for a success call with Brigitte, my wife, who was not able to join us today. She can show you how to use the system and do a free analysis with you during that call. And then you can get started right away. Okay. Do we have any questions about training? All right. Yes? Yes?
The clinical will be more case studies?
Yes.
Mostly case studies? Or
The clinical course will follow volume 2. So we'll talk about asthma, upper respiratory infections, dysbiosis, liver drainage, pancreatic drainage, and disorders related to that. We'll talk about thyroid disorders, and we'll also talk about spasmophilia.
So with theory first and then than case studies?
Yes, but the theory is specific for each condition that we're going to be talking about. So each time we'll have diseases of the organ itself, like adrenalopathies, like adrenal fatigue, and then we'll have a second module that'll talk about disorders that are based on adrenal imbalance, asthma, eczema, migraines, etc.
We submit cases or you?
With cases.
You submit cases or we submit cases?
I'll provide the cases.
Provide the cases.
Yes. Would you like to provide the cases?
Yeah, would be great to discuss.
Well, I'll provide the cases that we'll teach off of. Come on in. That's okay. I'll provide the cases that we teach off of initially, but we can certainly look for opportunities for you guys to bring your cases and for us to discuss them together. That's a good idea. Yeah, okay. Well, let's go over the workshop material before we begin. Okay. So if you want to look at your, that handout that says Science of Endobiogeny Clinical Workshop, the first two pages or so are information that I've taken from our master class. So you have this information now. It's signs, symptoms, and examination findings related to the autonomic nervous system. And then you'll see signs and symptoms related to the corticotropic axis. So what would be some indications of weak ACTH or strong ACTH or cortisol or DHEA? And then you'll have a page on thyrotropic hormones, so TRH, TSH, T4, and T3. It's kind of like playing bingo. As you're listening to the anamnesis, you can start to mark off or make a note. Oh yeah, the patient expressed such and such symptom and it's related to this. We won't really be talking about spasmophilia today, but there's information about that, so keep that and benefit from it. Okay, pages 8 to 12, which are the last 4 pages. I've created a diagram for you to use to organize the information as you're starting to build up your rational assessment and determination of the patient's terrain. Where are the imbalances for this patient? So I printed 4 copies. One is for the anamnesis, if you wish, one for examination, one for the 2 for the JEMMA panels. It looks like this. I know I changed the order a little bit. But here, just to remind you, remember that model I showed you before? We have the autonomic nervous system. We have the 4 hormonal axes. I've expanded the number of hormones here for your reminder and benefit. And then I've expanded the emunctories that are related to each of these axes. And specifically for the case we're going to be talking about today, well, let's start on the case and then we'll show you this. Okay. Thank you all. We'll get started. Right, I realized that was only supposed to be 30 minutes, but it's okay. Right? All right. So what I'm going to do now is I'm going to take you through my process of evaluating a patient, but from your perspective. Okay? I'm gonna think out loud and I'm gonna tell you what I would be thinking as I'm reading information. But we're going to analyze and treat this case according to your knowledge, not mine. Because I want you to understand and appreciate that for those of you who've started studying with us, whatever you've studied until this date is enough for you to manage even a complicated case like this. You have enough information already to manage this case. Okay. So let's go. So here's the intake. I'd like to have a very detailed intake examination form. Maybe many of you do as well. And I like to read it the night before, and I start to make notes, and I start to think in my mind, what is the endobiogenic terrain? Because the history is going to help me determine the next day what questions I want to ask of the patient. Because when you look at our material, when you read our books, you think, I could spend 4 hours with a patient. This is not practical. You don't have to spend 4 hours with your patient. You could spend 15 minutes. You could spend an hour and a half. I spend an hour and a half to 2 hours on a new patient. But we're going to go through this very slowly and sort of think about how we're thinking. So Alexandra is our patient today, and I want to thank her very sincerely for being our teacher and for sharing the gift of learning from her life and her experience. As we would say in America, where she's allowed us to be part of her healing journey, and we thank you for letting us walk with you. So her chief complaints are high blood sugar, fatigue, and pain in her hand, specifically the right thumb. And she has a history of type 1 diabetes mellitus, which developed in her early adult years, and we'll go in through that. So right here, I'm just thinking to myself, okay, there are these chief complaints, but there's this underlying condition, which is type 1 diabetes. Now, right here at this point, I want to understand, where should I be focusing my thinking in terms of this diagram? Well, I want to think about the autonomic nervous system, right? And which branch? Yes, parasympathetic, primarily. And there's going to be other reactions that are going to develop, because we know that the vagus nerve has an action on the pancreas. But the higher your parasympathetic tone is, the higher your alpha sympathetic is, and vice versa. But in terms of the endocrine system, where do we want to think about a condition like diabetes?
The fourth anabolism or somatotropic axis.
Yes, we want to think about the somatotropic axis. But there's a little bit of a tricky thing here. Go ahead.
I want to hear what you want to say.
Well, there's actually a ground zero, which is here.
Yes.
Why did I put a bracket over these two? Because there's something that we call the thyrosomatotropic axis. Because the hypothalamic hormone of the thyrotropic axis, TRH, I don't need to point with my finger, I can do this, is the hypothalamic hormone which stimulates prolactin, which is in the somatotropic axis. Why? Because prolactin stimulates insulin release from the pancreas. Have you ever thought about why, historically, the vast majority of cases of type 1 diabetes occurred in childhood? I know now there's an increasing frequency of adults who are being diagnosed with, like, in their 30s and 40s. But
because of the growth hormones.
okay, growth hormone is one thing, yes. So this is, go ahead.
Maybe because of the metabolism is very accelerated.
Yes, the metabolism is very accelerated. And in childhood, the thyroid hormones are very strong. That's why children, especially under the age of 7, have bright eyes, they're curious, they learn quickly, they're physically active. Sometimes you see children who are 2, 3, 4 walking on their toes. They won't even let their feet touch the ground. And that's coming from the influence of this thyrotropic axis, and especially TRH. And TRH's action on prolactin and on the pancreas help fuel provide the glucose that's necessary for this intense level of cerebral metabolism. And secondarily, we're going to think about the corticotropic axis. Why? Because what I didn't tell you initially, because didn't want to overwhelm you, is that this series of 4 hormones repeat themselves in a second loop of activity. So actually, right next to the somatotropic axis is the second round of corticotropic activity, because prolactin stimulates CRH and ACTH to stimulate cortisol. So we're really going to be focusing on these two and this. There is also something going on here, but I'd end up teaching you an entire course on type 1 diabetes, which is not what today's thing is about. So look at here. In all 3 of these axes, we have the liver playing some type of role. So we really want to pay attention to the liver. And just at your level of current training, I know you can drain the liver. You can do it. And look what else comes up is the intestines, right? Because the digestive tract, more broadly, is going to be involved in the processing of food as well as the processing of waste products. And we know that there is some correlation, probably, I'm not convinced that it's causation, but there's a correlation between the overgrowth of certain microorganisms in the intestinal tract and risk of type 1 diabetes, correct? Yeah. And of course, we're going to look at the pancreas. Now, I want to give you a broader sense of what the pancreas means and how it's related to the thyroid system, okay? And those of you who attend my talk tomorrow at the Gemotherapy Conference, you'll see this slide again. So how is it possible that the brain and the pancreas are connected to each other? This is really important for Alexandra's condition. Okay. In the frontal lobe, as all of you know, it's an area of the brain that's involved in logical thinking, and it involves a lot of dopamine. And in rational thinking, you need to break down ideas. It's analytical by nature. And in the same way that and people who tend to overanalyze and over-break down ideas, they also need to over-break down their nutrients. You see, there becomes a relationship between dopamine and TSH, because thyroid stimulating hormone stimulates the production of digestive enzymes, especially proteolytic enzymes, because the brain needs a lot of amino acids, right, for neurotransmitter construction, especially dopamine. Well, I mean, all these neurotransmitters, but dopamine is based on tyrosine. And I'm not going to go into all the metabolism, but TSH makes sure that amyloid proteins are properly broken down so they don't accumulate and cause various disorders. That's why TSH plays an important role in stimulating enzyme production. Okay, well that has to do with tomorrow's talk. Now, in the limbic system, in this more reptilian part of our brain, we have intense imagination, emotions, and memory. And here, TRH plays a role. Because TRH is not only a hormone, it's really a neurohormone and a neuromodulator. Because in the brain itself, TRH has synapses with the limbic system. And TRH is what causes our recollection of memory, and our experience of current events to be so intense. And TRH itself has a direct action on the endocrine pancreas for fugacious energy and inflammation. So we're going to see how this relates to Alexandra. And of course, TRH is related to the rate of T4 metabolism to T3. And so that part is for the talk tomorrow. Okay, let's get started with our case now. So we know that we want to focus on thyrosomatotropic and somatotropic activity, and we want to understand what was happening in Alexandra's life when she had diabetes. But she comes to us right now with these specific issues: fatigue, she says tiredness, and pain in the hand. So as far as the tiredness, what are we going to think of? What are the axes that are related to energy production?
Thyroid axis for energy and corticotropic fatigue.
Exactly. So now we have another reason to look at these two axes. So Alexandra wears a continuous glucose monitor, and she has a hemoglobin A1C that's between 6.5 and 7%, which sounds really ideal. But I'm actually, as I'll show you at the end, I'm not happy with this. I think it's too tight. And I'll explain to you why. You can believe me or not. We'll look at the evidence together. So she also has autoimmune thyroiditis, euthyroid. I think, as many of you know, patients with type 1 diabetes have a very high incidence of also developing other autoimmune disorders, starting with the thyroid and arthritis. Okay. So what symptoms have been recommended? So Alexandra is a naturopath and a herbalist by training. So she knows how to take care of herself. And even before she received that training, you were already using diet, right, to intensely and very effectively modify and maintain a healthy blood sugar level. I wanted to clarify with you about your diagnosis of endometriosis. When did that occur?
That occurred in December 2024. No, 2023, sorry. December 2023. And I became pregnant in May 2024. So a few months after I was diagnosed with endometriosis, I actually started taking high doses of vitamin D. Mm-hmm. And that had a serious positive effect on my sexual organ state. So I was able to conceive and keep the pregnancy.
Despite the endometriosis?
Yes.
Okay. So there is something obviously here with the gonadotropic axis, and we're not going to go into it today because we'll be here till tomorrow morning. All right, then she had some issues with the parathyroid hormone, which for us is part of the thyrotropic axis. So this is just yet another dysfunction. Okay, so we understand at this point where we need to be in our map, right, of the endocrine system and the terrain. Let's go back to Alexandra's childhood and understand the developmental factors that could have influenced the expression of type 1 diabetes. So if we come back here for a moment, I'm particularly interested in understanding how TRH could have played a role in Alexandra's childhood to entrain or create a type of fixed hyperactivity of TRH and its action on the pancreas, especially related to the brain and emotions and feelings. Okay, even if you're in the class, maybe you don't remember, so I'm going to pull up the material really quickly from our last seminar. Let's see. Go back here. Yes, let's look at the art of the history. Let's look at the phases of life. Okay. Okay, so we're going to be looking here. Wow, this is not helpful. Okay. Can you guys see this here? All right. So, do you see here, we're just looking at childhood. And in green, from 1 to 7, we have thyroid activity. For the first 3 years of life or 4 years of life, it's thyroid metabolic. Then it switches to thyroid endocrine and tisular. Don't worry about what that means. But the thyroid system, as I mentioned earlier, is very important in childhood development. We all know this. We all learn that if children have hypothyroidism, that they're cretinism and mental retardation, and we want maternal TSH to be below 3.5 or whatever for optimal neurologic growth. But that's because the thyroid system is so critical in the development of neurologic tissue and ectodermal tissue and ectodermal structures in general. So I really want to be focused on what happened in this age, because T3 is very important, and TRH helps convert T4 to T3. It accelerates this process. Okay, so now we're going to pop back to, not there, to here. All right. What else am I thinking about? I want to think about dysbiosis because of its relationship to diabetes type 1. And Alexandra was born by emergency C-section. So she didn't have that exposure to vaginal flora. She had lots of black hair. Now, part of that just could be ethnic. Some areas of the world, generally you get to Southern Eastern Europe, Mediterranean. Children tend to be born with darker hair and more abundant hair. But why is that? It's because the way their adrenals respond in intrauterine is much more reliant on DHEA than it is on cortisol. And children born in Western Europe and in England and Ireland, they tend to be fairer and have less hair, and if they do have hair, it's very light in color, because their adrenals tend to use more cortisol to drive that intrauterine growth process. That's also why they tend to be born more and retain the blue eyes than in other cultures. So I'm not sure in this case, did other children in cousins or whatever also have a lot of black hair?
Yeah, I think it is my family.
Yeah.
So my father's family were brunette.
Mm-hmm.
So all my siblings on his side also have lots of dark hair.
Okay. Was there maternal stress? Yes, she was being treated for hypothyroidism. Does that mean she was hypothyroid and she couldn't conceive?
Correct.
So then she was treated. Okay. She was a night owl with a cortisol imbalance before the pregnancy. Can you tell us more about that?
So my mother had to work and study at the same time. So when she turned 20, she was working Monday to Saturday, like the communist period, and then Sundays she would go to have her courses at university. So it was this kind of work and study without any break. And because they were living in an apartment where her room was, the parents would go through the room, she actually had the peacefulness to learn while after everybody was going to bed. So then she became a night owl. Yes, and I think that was the moment when her thyroid went off.
Mm-hmm. Okay. And did she continue to be studying it and staying up late at night when she was pregnant on you?
Yes, I think so. Yeah, it was much later. It was about 14 years later than that. But she got into the habit of staying late.
Mm-hmm. Okay. So there's some connection clearly between maternal physiology and fetal physiology and the general trajectory of the child. again, for those of you who are in the course, you'll recall that we talked about this, I think, at the end of this chapter. We have the trajectories right here, maybe. No, not there, that one, but we'll get to it. Yeah. So if you look here in the chapter 13 of volume 1, we have some examples of how the intrauterine period can throw off this ideal course of development in black in various ways. So there's a maternal infant reaction that's been pretty well documented at this point. And then we'll see how Alexandra's temperament and her personality developed as well. But we're anticipating here that she didn't start with this optimal course and then have something happen, that the disruption already started happening at this point. She was only breastfed for 3 days because her mother had to have surgery. So that here's a second level of impairment of the immune system because she wasn't getting immunoglobulins from her mother. So her temperament, so this, she was calm and she slept continuously through the night. So I always tell the mothers in my practice, easy babies make for difficult children, and difficult children make for easy adult children. So what do you think I mean by that? What is an easy baby? How many of you have had children? Okay. So I've had 4 children. So, I mean, I didn't push them out, but I have 4 children. What is an easy baby?
Sleeps all the time, eats everything, and
It's quiet. Yeah, and plays alone.
Quiet, play alone, eat when everything you give him to eat.
Yes. So do you guys hear this in the back? Easy babies, they sleep a long time, they eat whatever you give them, they don't cry or fuss, and they're able to sit and play by themselves. So in terms of temperament, what is that? What branch of the nervous system does that best represent? Parasympathetic, which has a strong activity on the pancreas. And children who can play alone and amuse themselves have a very strong TRH, because TRH also plays a positive role in imagination. Because children who want to play with other children, it's not that they lack imagination, but they're drawing their energy and their inspiration from the relationships that are occurring in the moment. There's a type of contagion. They're much more subject to emotional contagion. If there's enough children that are running and pretending that there's a monster chasing them, they just start acting the same way. And they don't even know why. It's what we call emotional contagion. It's just like a germ, like a microbe. They pick up emotions. But to the children who don't need that, have a high TRH, and they're vagatonic. They have a strong parasympathetic nervous system. So we see that we're somewhere in the realm of plausibility here. Our London workshop, and I'm thinking we should give CCME, which is continuing canine medical education credits. All right, so we're going to move along now and just kind of focus a little bit. So before the break, we talked about TRH, and we talked about how it's very prominent in the first 3 to 4 years of life. And what we see here is that age 3, I've highlighted it for you. Alexandra was sent to a weekly kindergarten, and she got a serious cut on her hand. And it's a pretty substantial cut, and actually you can just feel the trauma. It's still in the wound itself. And it's interesting because she resonated with the question of stress in her childhood and decided to mention this cut. So clearly it was impactful. And then when you go on to see how she said, after that episode, I was sent to live with my maternal grandparents. My mom started to work and had no time to be with me. So what I would like to do is explore with my patient during the consultation a little bit more about the relationship with the mother, a feeling of abandonment, and of course we're dealing with diabetes, which is an inability to handle sweetness and sugar. So I know I'm combining my reading of the history and my consultation, but let's do that just to save time together. So Alexandra, what was it like, if you can recall, to go to kindergarten at 3 years of age? That seems a little young.
It was very stressful. I remember I was taken by a big bus from home, and it was collecting children, and then we were going to this military garden, actually. And we were staying from Monday to Friday there without seeing our parents. So we used to sleep there, and then we were taken back home for a weekend, something like this. Yes. So I remember missing my family a lot.
So it was like a boarding preschool.
Preschool, yes.
And you felt that you were missing them.
Yes.
Mm-hmm. And how did you get the cut on your hand?
So I was playing with the Lego, with the children around, and somehow a piece of glass, a broken glass, was in between the Lego toys. And one colleague from there just came and scratched my hand without any notice. So I didn't see the scar until I was bleeding, and I was bleeding a lot. And the problem was that the educator wanted to cover her negligence and tell my mother that I got scratched my skin. And she just put some tissue over it and said, don't take it out until 2-3 days later because it needs to heal. And when 2-3 days later my mother took it off, just the skin started to
dehiss,
yeah.
separate again.
Yeah, it was coming together, but it was a very deep scar. It was not just a scratch or something. Yeah, so it was. She was not informed of the severity of what happened, and that it was the moment when they decided to take me off that kindergarten and put me into a kindergarten that is from 8 to 12, and I should live with my grandma so she could go and take me to the kindergarten and then take me back.
And did she live in another town?
She lived in the same neighborhood. So my mom was close to me. She came to see me every day, but that was for half an hour or an hour each day. Yeah. Mm-hmm.
And so, what did you think as a child about your mother's decision to do that? Did you feel? Yeah, go ahead.
So, as a child, I couldn't understand why that happened, of course. The issue is that the economical issues that were in Romania at that time, it was financial insecurity. So for my mother, between being with her child and keeping her job, more important was to keep her job, because otherwise we wouldn't have food to put on the table. Mm-hmm. So you see, she had to make a choice. And this mm-hmm. was how she explained it to me later as well. Like, she didn't feel she could actually choose what mm-hmm. to do. It was very difficult times, yes. Mm-hmm.
It seems like mentally
mm-hmm.
it's still difficult when you think about that.
Yes, it is.
It seems more mentally than emotionally difficult. How do you feel about it in terms of that contrast?
I have a child today, so if I were to choose between keeping my job and being with my baby, I think I would choose my baby. Mm-hmm. Because always there will be a means to put the food on the table, but to nurse your child, nobody can take care of that.
Yeah. So we see how impactful this was at 3 and 4 years of age, and how intensely it still affects Alexandra's experience of selfhood and a relationship to the mother, and the sense of sweetness and security. Would you say that's fair?
Correct.
Yeah. Well, let me just point out one other thing, because remember, we from our model, just from even our standard medical approach, we understand that the pancreas is going to be in the somatotropic axis. And we see that Alexandra had polyps that were removed at 2 years of age. And polyps grow under a condition that includes elevated level of growth hormone and inability to efficiently remove certain toxins. Okay. Can you tell me more about the salmonella infection? You were 12. It says could move body. Do you mean you were not able to move your body?
I couldn't, yeah. I couldn't move my body for about 10 days, yes. You know, it was that period when McDonald's came in Romania. So everybody wanted ice cream from McDonald's.
So it's like 2000.
Yeah, around that period, yes. And one friend of mine came to visit and she brought some Coke. So you can imagine the combination of ice cream with possibly salmonella in it and Coca-Cola. It just created in my body a reaction that in the next day I couldn't, you know, I was so sick I couldn't move.
Okay.
Yeah.
All right. Then at 18 years of age, you received vaccines. You were a booster for hepatitis B. Were there other vaccines you received?
Just for hepatitis B. It was the last vaccination from the vaccination scheme. That was done in the high school.
I see. Then you had an E. coli infection. So here, remember in our model, we can pop back over to look at this. We wanted to pay attention to the intestines, and now she's telling us that she's had 2 intestinal infections that were quite severe in nature. So we see also this disruption in intestinal integrity. Then at 23 years of age, you develop polyphagia, amenorrhea, flu-like symptoms. You had mono?
It seemed like because a few years later than this episode, I did my blood test and it showed that I had in the past mono. And then it was this single moment when I actually had the symptoms that I remember.
And then you were diagnosed with type 1 diabetes. That was at 23.
Yes.
And that was after all of this. And how close was this diagnosis to your birthday?
The diagnosis was about 6 months before I would turn 24. So about half of the period.
Okay.
Yeah.
Just share an observation from my work in pediatric intensive care. I found that actually every single case of childhood type 1 diabetes occurred in the 6 weeks before someone's birthday, which I thought was interesting. But that's not the case in yours. There's something else going on. Okay.
But it could have been that the beginning of the diabetes would have been in that
Around
time.
your birthday.
Yeah, because my HbA1c was 12. So to get an HbA1c of 12, I should have had
Several
elevated.
weeks or months.
Yes, yes, it's very possible.
Yes. So when you were first diagnosed, how did the doctors recommend treatment and what did you end up doing?
So I was admitted to the hospital in emergency and they told me, did you know you're diabetic? And I was like, no, but I saw I'm sick, so I suppose something was wrong. And I had difficulty to breathe, so I was in ketoacidosis. And they actually put me forcibly on insulin to regulate my blood sugar. And of course I was taken out of the hospital with a treatment plan with insulin. I couldn't accept the diagnostic, so mentally I didn't want to be a lifetime user of insulin and that's it. So I thought I would be smart and I will become vegan. So I will trick the carbs intake, meat intake, whatever could elevate my blood sugar. And I was staying on salads for several years, which actually damaged all my hormonal system, even worse than it was, and brought me in a state where few years later I had to be put forcibly on insulin to survive.
Yeah. So, and at that time you had not been studying naturopathy. And
Years later,
herbalism. Yes.
Yeah.
And what did the diagnosis mean to you? What did you feel that you were losing, and what did you need to regain by not following the recommendations of the doctors?
So you see, the whole quest of my life was to be perfect. That was the problem. So I finished my school with 10 because I was expected by my parents to get a 10, especially from my mom. It meant to me that I wouldn't follow the expectations. So being sick was being imperfect. So I had to fix myself somehow. I didn't have information, I didn't know what to do. So I was just grabbing whatever was coming as a quick fix and trying that out. So I ended up educating myself because I wanted to have the foundations, the pillars to distinct correct information of incorrect. Yeah, and be able to support myself in a structured, organized way. So, yeah.
And let's see, is there anything else about your course of your diabetes you want to share with us?
I had several hospital admissions with ketoacidosis over the years, but the last one was in the day of my marriage. So after I got married, after the whole ceremony and everything, I was so tired and my body couldn't cope with everything. So the first night of, of my marriage, I spent it in hospital. So that was unpleasant. And since then, I was never admitted again to hospital. So I managed to, yeah.
But is that because you started on insulin? Or you were already on insulin?
I was
therapy?
already on insulin, yes. But I learned how to be more balanced with, diet, with my thinking, everything.
Okay. Well, let's pop down here to the, you have a lovely appendix here, an addendum. Here it is. So we answered this question, that's okay. You were kind enough to point out to us that your anti-GAD was not elevated initially, but it's gone up progressively over the years.
Correct.
And also the other markers. So, GAD is related to, the anti-GAD antibodies are related to blocking insulin production. And there's a relationship here with TRH. So again, if we come back to this diagram here, why would this thyrotropic hormone TRH have anything to do with the pancreas? Why? Because TRH is a neuromodulator. It accelerates the synaptic rate of firing of all synapses in the central and peripheral nervous system. And imagination has an unlimited amount of the only limitation to imagination is the amount of glucose you can have to feed your brain. That is the only limitation. That's why people faint. Some people will faint, they'll pass out with really bad news. Because the intensity of their subconscious and conscious thinking of the event is so intense that it immediately exceeds the ability of the body to deliver glucose. And the only option that the body has at that point is to shut down consciousness and to function in a vegetative state, to conserve glucose. So TRH is driving all this metabolic demand in the brain, and it wants to ensure that the brain has enough glucose to meet that level of metabolic activity. Because unlike muscles, the brain as a piece of fat doesn't tire. It doesn't have a gross physical movement to get exhausted. And that's why TRH has this action on the pancreas. And so, as in diabetes, especially in type 1 diabetes, but in either type, these antibodies are going to rise over time because your TRH is going to keep trying to solicit your pancreas and keep trying to help you deal with your preferred way of dealing with stress and creating a sense of mastery over your life, which is thinking your way through all your problems. Is that fair to say?
Yes.
Yes, you're a master planner.
Yes, I am.
And actually, as I sit here, I observe that Alexandra actually uses her frontal lobe a lot more, especially when recalling events. It's very factual. But fundamentally, it's the TRH that's stimulating the TSH, and you're having the secondary action on your pancreas. So as I'm starting to think about how I want to support Alexandra on her healing journey, I'm definitely going to be focusing on these 3 critical emunctories, right? I'm going to support her liver, her pancreas, and her intestines. This is where I'm going to start. But ultimately, I want to support her thinking style and how she relates to life, and talk about feeling her way through feeling problems and thinking her way through thinking problems, and encouraging more of an emotive type of experience of issues that are emotional in nature. Yeah. Does that resonate with you?
Yes.
And is that something you feel that you're already evolving towards?
I do.
Okay.
I am.
Okay. Well, let's look at in the, actually I wanted to know this. Let's start to look at her terrain and a review of systems, and then we're going to go and start looking at her GEMMA panels. So her palms are warm and dry. So what is the warmth from?
Autonomic system.
What else could it be from in terms of the autonomic nervous system? I mean, if they're cold, there's a strong alpha sympathetic that's constricting. So if they're warm, there tends to be more parasympathetic because it's vasodilating, okay? But they're also dry, which means that there's enough alpha that's constricting her sweat glands that her palms are not moist. So we know there's elevated parasympathetic and alpha sympathetic. And that's true at the feet as well, which means she doesn't have a lot of pelvic congestion. If she did, then her feet would be cold, even if her hands were wet or warm. I do want to understand a little bit more about your appetite. So I want to distinguish between appetite and hunger. So for appetite, we'll refer to that as the desire to eat, and hunger, the feeling that your stomach is empty. So in general, is it your appetite or your hunger that's an issue, or both?
I actually think I trained my appetite to be new. So I don't crave for sugar or for something that can raise my blood sugar. And I actually have issues to feel hunger as well, because when I have headaches or my belly is crumbling or something, I know I need to eat, but I don't have specific
Cues.
acute needs, feeling hungry,
Okay, so when the liver is congested, it sends anorexic signals. So it'll tell the brain to release anorexic hormones, which will suppress appetite and sometimes can also suppress hunger. Because the liver is saying, I'm congested, please don't overload me with food. She prefers salt over sugar. I mean, she's a diabetic, but there's plenty of diabetics, as all of you know, who prefer sugar still. But elevated salt means there's some elevated alpha sympathetic and adrenal function going on. So right there I'm thinking, okay, I want to evaluate her adrenal function, and we can either use the adrenal panel or we can use EndoCheck. We'll use EndoCheck today. Is she hungry in the morning? Not always. So again, that's liver congestion. So the liver's spending a lot of time trying to detoxify overnight, and it's still not done in the morning. The mouth is wet, so again, that's another sign of parasympathetic activity. We're going to explore this fatigue. Actually, let's talk about it now because we haven't so far. Can you tell us about your fatigue? When do you feel energized? When do you feel tired?
Generally speaking, I feel energized in the morning. So around lunchtime, I feel a little bit tired. I need to eat something. Then it's when I know I have to eat. And then I'll feel again a lot of fatigue in the afternoon around 4 p.m., 4 or 5 p.m. Things need to slow down a little bit.
Mm-hmm.
That would be my cycle during the day, basically.
So it sounds like there's an adrenal fatigue based on the timing. Can you tell us about the abdominal pain?
It's something that actually was happening when I filled out the questionnaire. It's not currently any longer. It was passing.
Okay. Excess belching and gas?
Yes, I had that.
And is it in response to specific foods?
Not necessarily, because I eat the same kind of foods. But after I eat, at some period of time, 30 minutes, 1 hour maximum, I have this effect.
Okay, so this is very helpful. The fact that the belching, the gas and the air is occurring 30 to 60 minutes after eating would indicate that the problem is in the small intestines, and that's where the bacterial overgrowth. Well, all right. I think we're coming to too rapid a conclusion. You know, to me, part of the art is not letting ourselves diagnose something too quickly. All we know is that there's something that's occurring in the small intestines that most likely involves bacterial overgrowth. Because if the bloating or the flatulence was occurring 3 hours later, it'd be more of a large intestinal issue. And those are generally facultative anaerobes. So it's a whole different thing. And what is it that you eat in general?
I normally have vegetables and meat for my main courses. In the morning, I usually have eggs with some sort of proteins. I can have mushrooms, or I could have some goat cheese. I would combine. And also I eat salad.
Okay. Have you?
No cereals, no bread, no rice, nothing.
No.
And have you noticed if the salads tend to make you more gassy?
Yes.
And do you do better when the vegetables are cooked?
Yes.
And how do you do with root vegetables?
Sometimes I roast them, but yeah, it depends.
Okay.
How I would cook them.
And do you also have flatulence?
Belching is more prominent.
Okay. Is the joint pain only in the right thumb, or are there other issues going on?
So in the right thumb is the most painful, but I wake up in the morning sometimes with numb hand, with all the joints numb. But during the day, this one is cracking. You know, I feel it cracking. And this developed after I gave birth. About 2-3 months later, I actually came back to a home which was not insulated. So I used to stay in cold rooms to pump milk and to deliver it to the fridge, which was in an unheated area of the house. So this combination of going, you know, in cold area and then in warm, staying next to the child, I think it created some imbalance in my joints.
Okay. So if it's worse and you have this kind of paresthesia in the morning, then in general there's acidity at the tissue level that's focused on the hands. And most likely there's an issue with renal drainage, because when the kidneys are not able to drain efficiently enough, the hydrophilic toxins have to go into another hydrophilic space. So they're going to go into the joint space and be stored there. And also the fact that it sounds like once you get up and you're no longer supine and you're walking around, it's better except for this right thumb.
Yeah, correct.
So there's probably improved microvascular circulation. So here I'm also thinking, I want to start to support microvascular integrity and the endothelial linings, thinking about the long-term health of our patient because of diabetes, even though her hemoglobin A1C is so good. Okay. All right, let's move on just for the interest of time. We're not going to go into this. Okay. All right. So we have a couple of choices for our investigation. We have the great luxury here that I asked Alexandra, and she was able to obtain a profile level 6 in the GEMMA system, which allows us to do the level 3 panels. Okay, so these have specialty labs like osteocalcin, alkaline phosphatase isoenzymes, lactate dehydrogenase, and creatine kinase enzymes. So with these, we can do a lot more. You can still do a lot if we wanted to today with just a hemogram. But since we have a fuller set of labs, let's take a look. Now we want to look at the thyrosomatotropic activity and also corticotropic. So actually the best place to start today is going to be the inflammation panel level 3, because it's going to be looking at all those things. So let's start there. Let's start with the inflammatory panel. All right. This is the level 3 panel. Let's just take an overview. First, it's going to evaluate the role of the immune system, and that's broken down into leukocytes, humoral immunity, and mast cells. And then it's going to go into hormonal activity. We have corticotropic, and inflammatory is related to the thyrocorticotropic relationship. Necrosis is really a thyrosomatotropic, so that's one way we can look at it. Here we're looking at the somatotropic hormones, we're looking at insulin, we're looking at insulin resistance, and the generation of free radicals. We're going to look at these one by one. And then we have a neurophysiologic evaluation of like a psycho-emotional source of inflammation, which is still related to TRH. So we see in terms of the immune system, there are a number of sources of inflammation. The eosinophil to monocyte ratio is elevated, so relatively speaking, there's greater eosinophils than monocytes. So there's a type of defensive inflammatory terrain going on here. And it could be related to atopic disease or some type of chronic low-grade inflammatory condition, which would be consistent with her condition. The interleukins are just on, they're technically low. I think this was probably rounded up from like 0.99. But it's being suppressed and it's favoring an immune hypovigilance. And we see that in the past she did have these infectious conditions and maybe there was something with her interleukins going on. Her histamines are elevated quite a bit. And so right now we're starting to think, well, her cortisol is probably not elevated. And in fact, we see that it's not. But she does have, but her histamines are playing this congestive role. And look right there, it says degenerative joint disease. Okay? So we can highlight that. So we want to pay attention to this. In terms of the endocrine influence, cortisol is not directly playing a role. But in terms of her general inflammatory terrain, this index is saying how much does the body use inflammation as a means of adaptation at the tisular level? And the answer is a lot, because it's 9 times above the normal level. And again, indicates low-grade inflammation. And necrosis is also playing a role. So that's 10,521, so it's about 5 times above normal, a little bit more than 5 times. So necrosis is playing a role. Fibromyalgia, chronic fatigue syndrome. Now, she's not at a chronic fatigue place by any stretch of the imagination, but I think actually you could get there in a couple of years. And I'll explain why. So we know that Alexandra is on insulin therapy. And I assume it's being delivered by pump. Is that correct? No, it's manually injected.
Manual, yeah.
You have a CGM, but you're manually dosing. Well, what you very typically see in patients with diabetes, type 1 or type 2, as you would expect, is that their insulin index will be elevated, meaning the action of insulin is very intense at the cell level. And in a sense, it's partially because the insulin medications are suppressing or impairing insulin resistance. And this is a challenge for Alexandra for many reasons. If you think about it, why does insulin resistance exist? Because the body will always try to raise blood sugar level and get glucose into the cell. It's the most efficient metabolite for ATP production. So why would we have insulin resistance at all? It's because the vital organs, the brain, the liver, the heart, the kidney, they need to be preferred. They need to be privileged in receiving glucose at the expense of the other organs if necessary. And that's why insulin resistance exists. The insulin resistance is imposed on those other organs. So the vital organs, or the noble organs, as they would say in French, would get preferential access to glucose. But when you have low insulin resistance in this modeling system that we're using, then these vital organs are not going to be privileged anymore. And organs that don't necessarily need as much glucose are going to be oversupplied. And then you're going to see elevated free radicals, harmful free radicals like we see here, which are multiples above the upper limit of normal, because all that excessive glucose is going to be metabolized to pyruvate, enter the Krebs cycle, and free radicals are a byproduct of this process of oxidative phosphorylation. And so I very commonly see this problem with patients who are oversupplemented for their autoimmune thyroiditis with thyroxine, or when they're oversupplemented on insulin. And that's why, in my opinion, your hemoglobin A1C is too perfect. It's actually problematic. I know this is very much against conventional thinking, but actually when I work with endocrinologists, which is rare because we're in the same playground, but we're not playing by the same rules. But when I do, they generally, and you probably heard this, they generally like to see hemoglobin A1C of 7 to 8% because they're worried about hypoglycemic episodes. Has anyone ever said that to you?
So I was told by my endocrinologist that I have to have an HbA1c lower than 7 if I want to have children and keep the pregnancy.
Mm-hmm.
So I had to lower to that limit. I had around 8, 9. It was my HbA1c, let's say 2 years ago. And I was more flexible with food. But yeah, for the purpose of keeping a safe pregnancy, I had to restrict a little bit my food intake.
Okay. Well, there's a couple of approaches we can take here if you don't want to change your insulin regimen, because maintaining that strict a range of hemoglobin A1c is important to you. I mean, it's important for me as well for you to have an optimal glucose management cycle, and because of these long-term risks of microvascular disease and organ failure, etc. But if we come down, I'm sorry, I totally forgot to go over the labs with you. So let's do that now. Okay. So she doesn't have she doesn't have anemia. Her eosinophils are not absolutely elevated. She doesn't have a true eosinophilia, but relative to the monocytes, they are predominating. It did strike me that her platelets are elevated, and we're going to see what that means in another index. What I wanted to talk about right now is her TSH. You're not taking thyroxine, are you? No. But her TSH is below 1. And while technically this is normal, and even in our system, it's in the optimal range, it's not optimal for her. Because this TSH of 0.98 is disrupting your somatotropic synchronization and the timing of nutrient entry into the cell. And I know that because of your necrosis being elevated and your insulin resistance being low. Where is that? So now I know I'm jumping ahead, but I want to start to think about treatments. So let's come down here. And for the necrosis, okay, so okay, I actually don't want to use any of these. I know this is my system and I wrote the algorithm, but I don't want to use these. I'll tell you what I do want to use. And it's going to come up in the thyroid panel. I want to use ZMIEs. I want to use corn silk as a gemotherapy.
Gemotherapy?
Yes.
Yes.
Why?
Therapy.
Hold on. Marina? Yes, because ZMIE slows down TSH action, and it's a hepatorenal drainer. And it contains salicylate, so it also has an analgesic activity. You'll see that in the in this. It's also floating around. You can look at our our materia medica. You'll see actions in the gemotherapy and other plants that you've seen before, and some that you've never seen before. So take a look at that, and we can just pull it up really quickly. Here. Okay. Why ZMIEs? TSH antagonists, anti-inflammatory, establishes timing of insulin sensitivity, hepatorenal drainer, anti-rheumatic. This, you see what a good plant this is for her. Improves connectivity of unilateral and cross-lateral hemispheric function. Do you ever feel that you have brain fog?
Yes.
Yeah. So the brain fog that she's experiencing, the difficulty, so feeling cloudy in the head, difficulty beginning to concentrate, is because of this low insulin resistance. This is affecting her ability to concentrate and privilege her brain. So I really want to use ZMIEs. This is obviously a very smart plant. I don't think we need the cinnamon right now because she's on insulin, and we're going to get a lot of the actions that we might have thought about with cinnamon or blackcurrant from the ZMIEs. Blood twig would also be a good plant to use. This is Cornus sanguinea. It's also gemotherapy. It's very good in states of necrosis and inflammation. And at a psychological level, when people need to cry tears of blood and really release something emotional, blood twig is a good plant to think about. Would you guys like to see quickly the actions of blood twig?
Yes.
Okay. So this is Cornus sanguinea. Oh, it's not here. Is it here? Okay, well, okay, no problem. It will be added, but I can bring it up another way. Materia B11. No, not that. Yeah, this. Okay. So we don't need the Cornus sanguinea because of the cardiovascular activity. Shock and cyanosis. General endocrine drainer, reduces TSH. #1 anti-necrotic. Stimulates Kupffer cells in the liver. So we could think about using it. Here's some indications: brain fog, fibromyalgia, chronic fatigue. Again, she's not there yet. If Alexandra had high cortisol and this low TSH and the low insulin resistance and the elevated inflammation, she would really be in a chronic fatigue, fibromyalgia type of range of activity. Let's think about Cornus sanguinea. We're going to get a lot of what we need with ZMIEs. And Alexandra already has a self-practice and a practice through her professional training that can address emotional issues. Yeah. Okay. We could also consider using arnica and mallow, which is Malva sylvestris, for insulin resistance. But again, she's on medication. If the patient wasn't on medication, then I would think about using these plants. They're very helpful with the low insulin resistance. But because she is, I'm not going to try to treat this because there's an iatrogenic effect going on. Okay, so we have some ideas here that there's definitely an inflammatory terrain going on, and I want to treat that. Let's go back and let's look at her immunity panel, because this is going to have actually a lot of ways of looking at the autonomic nervous system, at her adrenals, and her immune system. So we see that in terms of sympathetic activity, she doesn't have spasmophilia, but she does have an elevated sympathetic nervous system. But we also know that she has a strong parasympathetic tone, which is part of her temperament. So actually, Alexandra's natural state is to be calm and relaxed and live life at a slow pace. But she's living outside of her true temperament because all of the sympathetic tone has been adaptive. It's how you've ensured your own survival, right? It's taking care of yourself, learning how to control things, how to anticipate, how to be a planner. But there's a way to help bring you back to a center point if you can trust being in that place. But we see at the splanchnic level all of these different ways of looking at immediate adaptation, the synthesis of the autonomic nervous system, the adrenal gland, the thyroid, the immune system. If we come down here to immediate adaptation score number 3, the net effects of adrenaline, noradrenaline, adrenaline, cortisol, thyroid, interleukin-1, the whole shebang, it's elevated. It's elevated. So at the gut level, you're surviving at a very organismic level. I know you have a joyful life. Alexandra has a wonderful husband. She has a beautiful son. She is creating the life that she wants to live, that is meaningful to her. But at some level, your organism is in this constant state of fear and adaptation. I think it's still living life as a 3-year-old.
Very possible.
Yeah. At least that's what the indexes would suggest. Not because all 3-year-olds live like this, but because of what Alexandra had to face as a 3 and 4-year-old at the residential preschool or kindergarten was something that created it wasn't an environment of thriving for her, it was surviving. At least we can infer that from this. So I'd like to think about how we can support this type of activity. And I think, looking at you, that Matricaria recutita would be quite helpful, German chamomile. Also because the name mother is in the name of the plant, Matricaria, and it's about the care of the mother. And I think that this is one of the challenges in your life, is feeling that the matrix of the mother and the envelopment by the mother. So I think Matricaria would be a good idea. So we have Zia Maiz, we have Matricaria. So again, if you're not familiar or you needed a reminder, we can go here and say, okay, why Matricaria? So we see that it's wonderful for her digestion, increases secretions, eupeptic, aperitif. So this can help start to develop more appetite and recognition of hunger. It's also a digestive antispasmodic, also anti-inflammatory for the digestive sphere, antihistaminic, her histamines are high, antimicrobial, it's broadly antimicrobial. So to the degree that there's some dysbiosis, if it's SIBO or whatever it is, we could also use that. It's sympatholytic and vagolytic. We know that both of these branches of the autonomic nervous system are elevated, so that seems reasonable to choose that. Now this osteoarticular analgesic and anti-inflammatory is more with the essential oil. But look at this beautiful decongestant activity, hepatic, splanchnic, and pelvic. So this seems like a very reasonable plant to add. Okay. So we're looking at the immunity panel. The histamines we can also address with the German chamomile, the allergic tendency. There's also a little bit of this allergic personality tendency, especially in structure. So what does this mean? This is the tendency, are any of you psychiatrists by training or familiar with this term allergic personality? Did any of you see the play by Neil Simon called The Odd Couple, or see the television show? Okay, maybe they didn't show it during the communist period. Anyway, an allergic personality is someone who tends to kind of be a little wary of others, doesn't like surprises, they like to be able to monitor or control things in their environment. Like if it's too stuffy, they want the window open. If it's too cold, they want to close it. There's this type of tendency that's called an allergic personality. Do you see any of those things in yourself?
Yeah.
Yeah. And her chemical sensitivity is high. So here the allergic personality being high in structure means that this allergic tendency as a personality type is more likely to be occurring in her family life, in her personal life, in her relationship with close friends or family, not so much in her professional life, where she's more likely to be collaborative and pragmatic. Is that correct?
Correct. Yes.
Okay. And she has chemical sensitivity. So here chemicals, not just synthetic chemicals, it also refers to the moiety. The chemical moieties are signals on foods that she could be also having some type of part of this a SIBO or intestinal permeability issue could also be leading to the joint pain that she's experiencing. So I would want to address intestinal inflammation, which we will with the matricaria. But I would also think about going on a very low antigenic diet. And so actually my preferred diet for you would be a carnivore diet for 6 months.
Okay.
So the carnivore diet would be nothing but meat, especially fatty red meat whenever possible, and eggs, and you're cooking your food in butter or tallow or lard. So this is what you would eat. And you could also have fatty fish if you like fish.
I like.
And after the first month or two, if you want, you can introduce some dairy products, the cheese, cream, yogurt, that type of thing. I think that would actually be very helpful, obviously because it's extremely low glycemic. And it'll put you in a mild ketosis, but I don't think it'll put you in ketoacidosis as long as you closely monitor your glucose, which you will.
Yes.
Yeah. All right. Now, I know I don't have time to go into all of this, but this group of indexes are meant to look at the risk for global autoimmunity. And without going to the details, she doesn't have the pattern that would be associated with global autoimmunity. So I don't suspect at this time that there are other autoimmune conditions that are going to be developing in the near future. Of course, this could change at any time, but I feel reassured when I look at this that that's not the case. Well, let's look at the thyroid and adrenals, and we'll wrap up. So here we're looking at thyroid panel level 2, which is the functional thyroid assessment. We see that the TSH is marked as optimal because it is in the optimal range, technically speaking, but not optimal for her. Her T4 and free T3 are in the normal range, but they're suboptimally low. Okay, so that's something that we want to think about improving, but we're not done looking at the panel. Her TSH to T4 ratio is actually optimal, but because of the suboptimal free T4, I would say she has a suboptimal normal thyroidism at this time. And her T4 to T3 ratio is optimal, despite both of her values being suboptimal. So there's still something we need to do to improve the general efficiency of the T4 conversion to T3. But look here. The thyroid index is looking at the final functional effect of T4 and T3 in driving cell metabolism. And it's actually slightly elevated. And her thyroid yield is elevated, which is saying overall, from TSH to cellular thyroid activity, you're too sensitive. And this is what is driving you as a person. You have this, thyroid energy is like tip of the spear. It takes you through the whole day. So in terms of thyroid, I would say it's slightly excessive. And as we saw in the inflammation panel, it's part of what's driving this inflammation, this inflammatory pattern.
So what you're saying is that at cellular level, it's actually a signal of too much, like a hyperstimulation, like hyperthyroidism, if we can call it like that.
In a sense, there is a circulating suboptimal normal thyroidism, but there's a cellular hyperthyroidism going on.
Yeah,
Yes.
that's my question. Yeah.
Yes. Now, when we come to some treatment considerations, if we come down here, for example, it says if the TSH is 0.5 to 1, you can consider blocking with peachy motherwort or lithy, which is viburnum lanthanum. These are all anti-TRH products. Or you can use the corn silk. So that's the ZMIEs that we chose to use. I think that we should be using lithy, which is Viburnum lanthanum, to address TRH. And again, this is a whole lecture, which we're not going to go into. But all three of these plants, Fabiana imbricata, which is peachy, Leonuris cardiaca, which is motherwort, and Viburnum lanthanum, which is lithy, all address TRH. But they, in my mind and in my experience, they do it in slightly different ways. And Viburnum lanthanum, lithy, is especially good for TRH's intracerebral activity. So all of these things related to traumatic rumination, to fear, anxiety, vivid imagination, these types of things, you want to think about using lithy. So I think that part of your broader healing pan would be to add the Viburnum lanthanum as well. The other reason is when you start to block TSH with something like the ZMIEs, you have to be careful that you don't have a reflexive rise in TRH to try to overcome the blockage. So from an endobiogenic perspective, if you're blocking TSH, you almost always want to add something that also inhibits TRH. So because when would I have chosen motherwort? Well, maybe if Alexandra had arrhythmias or dysrhythmias or a lot of somaticization of anxiety, but she's not anxious. So motherwort is really not her plant. And the peachy I would add if maybe she has some type of issues of hyperplasia, or if God forbid she had a cancer, then I would really want to use peachy in that case. So that's what I would focus on. And by slowing down the TSH and the TRH, hopefully we can start to slow down that cellular level of impact of your thyroid hormones. Okay.
May I have a question?
Yes, of course.
How how often do you recheck the values after you give the supplements?
It depends on the condition. In this, typically it'll be every 3 or 4 months. Okay. If I'm making an adjustment to thyroid replacement therapy, I want to check them in 6 to 8 weeks. And because she already has suboptimally low T4 and T3, I'm concerned. I really want to monitor this, and I would check her in 8 weeks to make sure that my ZMIEs and my lithy have not further reduced the quantitative production of thyroid hormones. It's a little bit of a tricky balancing act that we have to do. And maybe we end up adding a vena sativa, milky oat, as well. And we could do that as a gemotherapy, as a tincture, as an infusion. But I want to keep that in mind and not rush into that. This is the EndoCheck panel. It's going to give you a broader overview of primarily corticotropic, gonadotropic, and a little bit of thyrotropic activity. And we can see here that her adrenal status, her cortisol is normal. She's in the B status, which is green. But it says that it's not optimal because she has elevated adrenal anabolic steroid activity that is impairing her adaptation. So here we see specifically what type of adrenal fatigue she has. It's not because her cortisol is low, it's because the anabolic steroids are coming too early and trying to short circuit or end her adaptation response. And this type of person, adrenal steroids, especially DHEA, is really about standing your ground and becoming like a mountain, being immovable and implacable and not giving up.
It's me.
That's her, right? So she's living through this resistance.
Yeah.
It's a type of stubbornness. I will not go down. I will not go away. You will not defeat me, and you will not tell me what to do.
Exactly.
Yeah. So here, you could use ribus nigrum because it is really a very it is a very polyvalent adaptogen. But the recommendation is really to think about more ergotonic adaptogens, and we'll get into that. And we really need to start rehydrating the adrenals. Okay? Let's look at the, but don't worry about all this. We don't have the time. We're not going to go through this. Let's look at the actual indexes that went into the calculations. So there's our normal cortisol. Her adrenal cortex index, which is looking at global adrenal activity but favoring the anabolic steroids, is high, and that's the problem because her ratio is low. Okay. I'm not going to go into this right now. Let's look at some treatment recommendations for her adrenal status. So you see here very clearly ergotonic adaptogens, chaga, reishi mushroom, marl root, which is a Siberian plant. This is Raponticum carthamoides, which I like very, very much, and Siberian fir essential oil. So we have a couple of options here. I did highlight chaga and marl root. I think both of these would be good, but I think chaga is actually better because it also has this cleansing effect, and it's also an ergotonic, like I said, adaptogen. I think what you could do is add chaga to your mixture, and you could have some Siberian fir essential oil to inhale in the afternoons, especially if you're outside the house and you find that you're tired and you feel, I don't want to drink coffee, but I want a little uplift. For adrenal rehydration, we could go with turkey tail, or we could go with yarrow. And the yarrow, you can drink as an infusion if you want. You could apply the essential oil over your adrenal glands anatomically. It'd be your choice, or you could add it to a tincture. But I think the turkey tail would probably be better here. And for adrenal hydration, we have parsley tea and celery juice. Well, we're heading into the winter, so I wouldn't recommend celery juice because it's too cold. But I think a parsley infusion would be quite good. Yeah. So the last thing that I want to talk about is drainage, which is actually the first thing we would want to do. But the best drainage is not always going to come from the JEMMA panel. Some of it we just need to understand from our approach. So for example, when I think about polyvalent drainers, what I really would want to use, first of all, would be agrimony. Agrimony eupatoria. Because agrimony, okay, I see some looks, so let's go to agrimony and see why it's such a wonderful plant. Okay. All right. Astringent, portal decongestant, regulates gut-brain serotonin levels, increases hepatobiliary secretions. Pancreatic drainer, stimulates exocrine and endocrine pancreas.
Can you show the name, please, again?
This is Agrimonia eupatoria. So it's what we call a dual pancreatotrope because it supports the exocrine and endocrine pancreas. And it increases hepatobiliary secretions. It's anti-inflammatory. It also has that antihistaminic activity. So this would be my most preferred plant to add for her. But it's okay. Let's say this isn't the right plant, or maybe you don't have it in your country, or you don't have access to it. We could use, for example, Juglans regia, black walnut, as a gemotherapy, as a tincture. We could make a decoction of the hulls. But this is also working on the exocrine and endocrine pancreas, It's very good for dysbiosis, for SIBO, for intestinal permeability, for parasites. But that's not exactly your terrain, so I don't think that's what we need. But you could use that. You could also use, what else could you use as a dual pancreatotrope? Gosh, I am blanking because I think I'm tired. Let's see. Probably Rubus fructicosa you could use. Rubus fructicosa, so that's like blackberry or bramble as a gemotherapy, as a general pancreatic drainer.
It's an antifibrotic actions very high in Rubus fructicosa chemotherapy.
So let's pull that up. Okay, well, I don't have it in here. So this materia medica relates to everything that's recommended in the panels. Okay, but Rubus fructicosa you could add as well. So let's consider that.
All three are related to pancreas?
Yes. I would also like to use, we want to have some type of hepatorenal drainer. And again, we could use a number of plants. I think the most appropriate here initially would be Juniperus communis, because it's a good hepatorenal drainer, but it has a strong indication when you have autoimmune disorders, especially multiple autoimmune disorders. And it also has this aperitif and eupeptic quality as well. It can also help, it's sudorific, it's anti-neuralgic, so that could help with that matinal paresthesia that you have. Number one hepatic and renal drainer. Used in autointoxication and autoimmune disorders. So we have Juniperus, add that. And later, for example, we could evolve her to Betula pubescens if we wanted, or other forms of birch for general hepatorenal drainage. Some people do not, maybe 15% of the time I found people do not tolerate Juniperus communis. It's just too intense for them. It's not actually an aggressive drainer, but there's something about the quality of Juniperus which can feel too intense for some people. And then if that's the case, I'll switch them over to Betula. Also, when you're using the materia medica, under the indication section, it'll recommend other plants and sometimes homeopathics and oligo element therapy like minerals and vitamins, minerals that you can use for very specific conditions for optimal effect. Yeah. Okay, so I know we're running out of time and we didn't get to do the physical examination today, but that's okay. We're going to leave it just at this. I want to summarize what we said we were going to be using and what the effects are. So, okay. So we have this thyro. Let's do this thyropancreatic. I like to combine the plants together with a sort of an affiliated or integrated series of actions. That way, if the patient is under-responding, you can increase the dose of everything that's working in an associated field, or if they're over-responding, you can reduce the dose without having to make up. What the heck is that? Oh, okay, weird. So we talked about using viburnum, lanthanum. That's anti-TRH. And trauma we'll put. And pancreas stimulation, anti-GAD rising. Then we had ZMIEs, which is also gemotherapy. This is anti-TSH, hepatorenal, joints, inflammation. Then we have matricaria. So we can do this, ANS, thyropancreatic. Can you get this as a mother tincture?
I think so.
Yeah. So this is ANS, digestive, histamines, intestinal permeability, and dysbiosis. Rubus. This is pancreatic drainage. And then we had, let's see, chaga, which is inonotus obliquus. And so this is for, this is ergotonic, adaptogen. We have turkey tail, which I honestly cannot think of the here we go. The mushrooms are in a separate section. Okay. Oh gosh, I didn't put turkey tail in here. Okay, that's all right. So I'm just going to put turkey tail. This is adrenal, rehydration, immunity. And we're going to put in the other drainers. So what do we have? Juniperus, communis. Do you think you can get these in their spagyric form? Or
I think it's
or
possible
fluid
to
extract?
source them. It wouldn't be a problem.
Okay, I'll put fluid extract or spagyric. And that's it. So we can call this adrenal drainage. Oh, we talked about agrimony. So we'll put agrimony. Can you get that? So let's say we have equal parts. And I tend to go on, well, lower than herbalists tend to go. So for something like this, I would say we could do 3 mLs AM because she has good energy in the morning, but do, let's say, 4 to 6 mLs at 2 p.m. to try to stave off that late afternoon fatigue. And for this, I would do 4 mLs twice a day.
Combine, or you put 3 milliliters each of those four?
So it's 3 milliliters of this combination.
So you combine the gemotherapy and the mother tincture and all in the same
Yeah. Yeah.
bottle?
Yeah. And I'll add essential oils and homeopathics as well.
In the same.
Yeah. Flower remedies, they all go in. It's just like making sausage. Just put everything in there. It's all going to work.
It's a cocktail.
Yeah. Cocktail probably sounds nicer. Yeah. And I think equal parts of these are fine as well. Well, I want to thank you all, and of course I want to thank Alexandra for instructing us today and for being brave enough to share her story with us. Do you guys have any questions before we conclude?
Do the GEMA program gives you the dosages, or do you decide those?
You need to decide yourself. What I didn't talk about today is that you'll see here, for example, we have a line that will be coming out either in late December or early January called Endobiogenia. And there are various remedies that I've composed, like catavants to help support the adrenals. There's thyroid remedies, neuropsychiatric remedies. There's various remedies. And they combine a lot of the recommendations that are already in the panels. And so they have the optimal combination of neuroendocrine and drainage formulas to treat these conditions with recommended doses. And the Endobiogenia products are liposomal preparations. So they're very bioavailable. They'll start to be absorbed in the stomach and in the first part of the small intestines before hepatic first pass metabolism. So they're also concentrated tenfold. And so the dose will be 5 to 15 drops. Yeah. For an adult.
Will those be available in Romania?
Yeah.
To be bought?
Yeah.
Can you please show again the recite for Alexandra?
Sure.
Thank you.
We're going to be sharing all this with you.
No.
Yeah.
And Chaga in Onotus and Trametes versicolul Turkitenga.
Thank you.
You made Trametes versicolul.
Yes, thank you.
My colleague discovered that
And then we also talked about diet, carnivore, lifestyle, Siberian fir essential oil in the afternoons for fatigue. Learn to feel your way through feeling problems. All right, thank you all for attending. It was a pleasure indeed. I know I'll join some of you for dinner later on tonight, and I hope to see some or all of you tomorrow at the Gemotherapy conference that's also being held here in this hotel. Thank you all. Bye-bye.